As part of the anaesthetic preparation for ActiveFx, we find that it's not really necessary to give IV sedation. I know that we used to tend to give a lot of intravenous midazolam, but if we use topical anaesthetic in regional nerve blocks, the patient will get a very satisfactory level of pain control, and especially we tend to use much higher laser settings than conventional. What we normally tend to use is something, I'm not sure if you can get it in the United States, is 23% lidocaine and with tetracaine as well, and the tetracaine is 3.5%, and we found that this is wonderful in terms of most patients, if you leave it on for an hour, will have absolutely no pain at all. So in terms of the topical anaesthesia, we really only need to do the lateral aspect of the face, because the regional nerve blocks will tend to cover most of the perioral area, and also we can get the frontalis through the supraorbital nerve. So in terms of regional anaesthesia, what we tend to use is xylocaine or lidocaine, 2% with adrenaline. You can get this in Ireland. You cannot get it in Britain, and I think you can get it in the United States as well. So we can see this little frenulum that exists at the edge of the third tooth. What I do is pull the skin down over the needle, and it doesn't tend to hurt the patient as much. And we know that the infraorbital nerve comes out through a little foramen just underneath the eye, and then I sort of hold the anaesthetic for a moment, and that allows it to infiltrate back into the foramen, and we tend to get a better lateral spread of the anaesthetic. Okay. So on the bottom is the fifth tooth across. This little frenulum is where we're aiming for. You can leave the buccal cavity open to give it, and I find sometimes if you let it close against the needle, you tend to get a better distribution of the anaesthesia over the nerve. Now the supraorbital nerve, which covers most of the frontalis first, except for the lateral aspect, can be got through the little foramen, which just sits there. Sometimes it's easier if a staff member holds it up for you, but I should be able to get it here myself. And what we normally do is hold it just in with the needle maybe down about a third or a quarter way, pointing towards the medial aspect, and we can hold it there. Very, very effective frontalis block for probably a period of up to 40 minutes. The next stage involves removal of the anaesthetic cream off the face of the patient. As we know, carbon dioxide lasers tend to be attracted to the water within the skin, and because there's a high concentration of water within the saline and the gel of the lignocaine that we're using, then the laser would obviously tend to sort of focus itself in terms of vaporization at a layer above the epidermis, which is what we don't want. We want to attract it to the water cells in the transitional zone and also within the epithelium itself. The next stage involves using tetracaine, not 0.5%, that we just use as topical anaesthesia. The patient, as you know, probably can get a little sting from that for the first 5 seconds. I find that sometimes when you warn the patient, they tend to get a bigger sting than if you don't. The next stage just involves putting some Visine, which is a lubricant. Normally the patient wouldn't feel this because they have got an anaesthetic in their eye. Good. In terms of the corneal shields, these are the ones that I find are preferable. They're the ones that you can catch from the outside, and there are many different devices, as you know, some with suction, some with that, but I find that these are the easiest to use. Well done. Just go in 2 seconds. Okay, in terms of the ultrapulse machine, we can develop short, sharp blasts either by pulsing or with continuous wave with a computer pattern generator. And we have to give some respect to, I suppose, Reliant, who invented the technology behind fractionalized resurfacing, particularly in the Fraxel. We all know that this is probably considered a better wavelength. Because I sort of grew up on the older ESC Sharplan type CO2s, I still like to run this on power rather than rate, but certainly you can run it in either. And in terms of power, I would tend to probably do everybody at around 18, but if I'm doing acne resurfacing, I certainly go 20, 25 and maybe even 30 watts. In terms of the energy, I normally run it from 100 to 125. Now, I tend to prefer a square pattern, as I presume most people do, which is pattern 3. In terms of the size, we'll obviously push it to see as much as we can do. The machine will tell me when it's gone too far. And in terms of density, I know conventional books will all say to run most faces on density 2, and whenever we get to density 5, we've almost lost the fractionalization effect because it's almost given total ablation. I still would tend to run most faces on density 4, and certainly whenever I'm doing necks or backs of hands, I'll drop to density 2 or maybe even 1. In terms of the repeat delay, I tend to prefer 0.5, and if we go into options, we can turn on the pole scan, and this is the computer pattern generator, and you can hear that the machine almost takes a different noise at that stage. And then the machine is now on standby, and this is when it will kick on. The plume from the vaporization will run through this machine, which is great, right through the head itself. And probably the best thing to do is get everybody first protected by laser wear. Probably the easiest place to start will be in the area that I know that the regional nerve blocks are. Very small, let me put it back down the stick. That is size 6. Obviously, if we do it at size 8, we can see the type of effect we get. The ActiveFx won't let me do it much bigger than that. If we run it on density 3, we can see the difference there. So probably density 3 looks like a good setting. Certainly a laziness within us. I've set that up to 1. We'll just run off too soon on me when I'm talking. Because we do know that if we, for instance, pull the machine back, we get less power. And it's nice to probably individually titrate the machine, but the maximum place where the machine's going to work is when this little metal thing is actually touching the skin. We also know that if we fire it at an angle, like this here, we'll get less power in certain areas than others. We know that if we pull the machine off, that we'll have less pain for the patient as effect, but if we can at all coordinate it through the screen, it's probably always preferable, because that is the way that the machine is made to work. And we can see it's a fairly painless experience. Now this patient has a lot of edge marks along the lip, so I probably would give her the benefit of the doubt by giving her an extra double pass in that area. We know that when we are double passing, you're risk of complications tends to go up either with pulse stacking or with repetitive pulses in the one area. And if we allow for a thermal relaxation time, the fractionalized resurfacing, because of the random settings of the computer pattern generator, will allow the skin enough time to settle down. And there's a couple of probably key places in the face that I would tend to run it extra. That'll be sort of around the jaws area. Now we're outside the nerve block area in this sort of area. When I'm doing around the eyes, often I tend to double pass just in the lateral aspect of the periorbital area, because obviously this is where there's been wrinkles. The supraorbital block will probably cover some of the eyelid as well, and normally the patient doesn't tend to find much pain in this area. Close your eye. Thank you. And I'm sort of going a little heavy here to try and achieve a little lift as well. Now open your eye. Thank you. Okay, keep your eye open. Well done. If this patient had an intraorbital fat pad, which she doesn't really to any great extent, I know we've seen earlier that she had a little one when I pursued her, I'd probably do a double pass underneath her eye. Now, normally when we do next, we drop the density to 2 or even 1, and that should be good settings for the neck. Now, we have a lot of experience in doing necks. We have done certainly as many as 2,000 at this stage without any problems. We find that if this is the epidermis and this is the dermis, in the face the two tend to mesh like this here. So that if we ablate one, there's quite a prominent number of dermal ridges that contain epidermis, and the epidermis has enough keratinocytes and cells to regrow itself again without scarring. As we get into the neck, and this tends to get less, then we find the layers are almost on top of each other like this. So that if we ablate off the epithelium, then there probably isn't enough little pockets of epithelium left within the dermal ridges in order to reform itself properly, and obviously the risk of having subsequent scarring, depigmentation, hypopigmentation, etc., post-laser resurfacing would be much more. So because of this, we tend to make up for it the other way around. So instead of shooting 4 or 5 down into a small area like this here, density 4, we tend to just shoot 2 at density 2, and whatever little bit of epidermis is there can correct itself. So normally with this technique, if you get prolonged erythema, then usually something's wrong, and you have to consider infection number 1, or the possibility of linear scarring number 2. Often it's very hard to make up your mind clinically because everything looks the same. So it's as well probably to certainly start off with, we tend to use Lamisil for the potential for infections, and if there's a possibility of bacterial infection, then obviously orally we tend to give patients ciprofloxacillin. Sometimes we use flucloxacillin, depending on whether we have any evidence of a Staph aureus. And bacterial infections can scar. Certainly viral infections, particularly if the patients are on prophylactic course beforehand, usually disappear to the day, 7 days later.